James Sutton. We're on Road to Recovery. My guest today is one of the members of Shatterproof. She's the Senior Director of the National Stigma Initiative, Rachael Cooper. Welcome, Rachael.
Hi, James. Thank you for having me. It's great to be here.
It's great having you. Can you tell the viewers how Shatterproof got started and what is Shatterproof?
Absolutely. So Shatterproof is a national nonprofit that works on the overdose crisis. We've been around for almost 11 years now, and we were founded in response to the passing of Brian Mendell, who was the son of our CEO in the early 2010s. And Brian's passing was related to substance use, and it inspired Gary to found Shatterproof to work towards solving the addiction and overdose crisis in this country.
Oh, okay. Now, you're a real man. I look at you have a great website, right? And you do so much. You have so many components: prevention, recovery, stigma reduction, education. So can we go down a little bit, like in prevention, what are some of the things that you guys do?
A lot of the work that we do in the prevention space really focuses in on education. So there's several different ways that we go about that depending on the branch of the organization. But education and awareness and building community capacity and engaging communities are really critical components of our work across the board. So that can look like online modules. It can look like, doing walks in communities. It looks like sharing stories, lots of different ways that manifests throughout our work.
Okay. And you're a national organization.
We are.
And that's something that was really lacking. It really wasn't too much organization, of all the different communities focusing on, the opiate crisis and then linking up. And you guys seem to be doing that very well. What are some of the activities that you do to pull that off? How do you manage to connect so many communities?
Well, a lot of it, starts with recognizing that we don't work in a vacuum in this space. Nobody does, right? You need the prevention, you need treatment and recovery, harm reduction. You need all of it to really create long-lasting and effective change. So a lot of what we do is we work both at the grassroots, working with people with, lived experience, people who have been personally impacted by an overdose or by substance use disorder themselves, all the way through to, the what we call the grass tops, right? So really activating, influential members, influential actors in the substance use field. So partnering with organizations all across the country, knowing that we have to kind of come at it from both directions, essentially.
Right. And that's what I really noticed, that you really have some heavy hitters in a lot of different, categories, doctors, experts in a lot of different fields, addiction and psychiatry and mental health, and a lot of people who are great philanthropists too. I see you have a lot of people who are very well known to be helpers in the community nationally too, What about peers? Have peers been helpful in your initiative?
Absolutely. So, for example, working on my initiative personally is the National Stigma Initiative. So working to end the addiction, stigmas are related to addiction and substance use. And one of our key components in our campaigns is story sharing and storytelling, right? And that often has to do with, people with lived experience, with peers sharing their stories, how they got to where they are, what the work that they're doing, really activating those influencers, those people who have that experience to really impact it, and it really create more influential change, I guess. So really looking at that. And then also we do have our Shatterproof Ambassador program, which is a program that that leverages, again, not only the voices of people with lived experience, but in particular their families, as well as specifically more to advocacy work.
Right. I was going to ask you that because, this program, Road to Recovery, see, I'm a person in long-term recovery. So we initially started this program to reduce stigma in Montgomery County and in Maryland.
Yeah.
And so we highlight, people with lived experience that, have substance use disorder and or mental health disorder and have, been in recovery, sustained recovery, change their behavior and are successful, right? We want to highlight because we notice that a lot of people, still look at addiction as a moral deficiency, as you're a bad person and that you'll never change.
Right.
And they don't see us when we change. They see us when we're acting out, on TV and in movies. But then we kind of disappear once we, recover. We integrate into the community and are never heard of again. So we wanted to highlight that we do recover and we are, some successful parts of the community,
Absolutely. One of the things that we look at a whole bunch of different types of stigma on the initiative, right? Because we have like public stigma. So, when you walk out the door into the world, what are the types of stigmas that you experience, right? Is it, people who, is it like social distance, right? Don't want to work with somebody with a substance use disorder, don't want to be a neighbor, don't want to, have in the community. Is it more, and then there's like, we all, all of us hold stereotypes and biases and prejudices. We've learned them throughout, our life, and it is part of our life's work to unlearn them, essentially. So then that's a lot of what we work on, is saying, how can we help unlearn some of these things that have been really since a very, very young age? So it's a very conscious sort of unlearning. But we look at that public type of stigma. We also look at, the structural stigma, because people are the ones that make policies. Policies don't spring into being from nowhere. So when you have biases and people who with biases making policy, that's where we do see some of that stigma as well, that can be codified into either like big P policy or little p policy, depending. And then we look at self-stigma too, right? So like, what do you believe about yourself? What gets ingrained? And when we look at this, one of our big questions was, how do you measure this, right? So how do you change this? You have to know what you're fighting, right? You have to actually know what you're looking at to fight the thing. And one of the conversations that we ended up having after running a survey tool to assess said levels of stigma across the country was actually kind of exactly what you're mentioning, which is that, not only do people not see that like people in recovery, that the change has been made, but the stigma still sticks with the label, even, if somebody finds out that somebody's in recovery. So if Rachel's in recovery and somebody finds out, they still don't want me as a supervisor or to marry into their family. And so one of the things that we really look at is that very much that recovery part. It's not only it doesn't end when somebody gets into recovery, is what I'm saying.
Right. It's true. Yeah, it's true. And now also, I noticed that you guys do stigma reduction with people who are on medication, right? Because that's a huge one within the recovery community. We are very, biased about people. I'm on an abstinence program, and then a person that's on methadone is not in recovery because they're not following the pathway that I followed,
Right. And that's, generally speaking, the stigmas against medications for opioid use disorder tend to fall into the lines of simply substituting one drug for another. That's the most common one that we pretty much hear. But then, there's also the idea of I'm cool with this, like this is great if it works for you, but I don't want it, in my backyard. So the not in my backyard, the NIMBYism component really shows up as well. So it's like, that's great. But, we also see high levels of support for like healthcare coverage of opioid use disorder, right? Which is really encouraging. We also see, really like structurally speaking, we see a lot of support for policies and healthcare coverage to really address, substance use disorder treatment, but within the recovery community specifically, and that the associated, like the different viewpoints on medications for opioid use disorder and whether or not somebody is truly in recovery is it's a very personal set of beliefs. And we talk about that a lot. There's a lot of questions on that and how to best navigate that.
Yeah, and I'm advocating. We advocate. In I work in a jail facility, right, in a drug program, and we've been teaching that there are many pathways to recovery as a way to reduce the stigma about how a person is able to manage changing their emotions and coming into recovery, because everyone we kind of frame it at, find a suit that fits you, right? Especially
Right.
now that so many people are dying with fentanyl. We really embrace opportunity for a person to use safely,
Right.
use Suboxone, methadone, Vivitrol,
Right.
and we see very few takers for Vivitrol. We don't see too much policy pushing Vivitrol as much as we see policy pushing methadone and Suboxone. Have you seen that nationally?
Yeah, I think that's fairly common. That's fairly common. For a few different reasons. I think part of it is, and I mean, I'm not a clinician, just to be clear. So like this is what we're seeing. I just want to be clear on that. But when you're looking at methadone or buprenorphine, and you're looking at an opioid agonist, right? So something that is still addressing essentially, for those of you who aren't familiar, kind of functioning similarly to a nicotine patch in some ways, where you're weaning off something using a safe supply until
Right.
and then that process can take any amount of time. You've certainly has taken different amounts of time for different people.
Sure.
But part of the Vivitrol, is with it blocking, right?
Right.
Blocking the impacts of opioids. I think it's a different commitment type, and some people really want that. They want that this just won't work in my body. I don't have a choice. And some people, that's not necessarily right. And it's also, not clinically, indicated for people who are pregnant, for example. So some of this is also just dictated purely by the medication itself. But
Okay.
I think Vivitrol is certainly one of those ones that feels a little bit, it just feels different for people, likely in part due to just a completely different chemical composition.
Okay.
And there is also an elevated overdose risk at the end of that Vivitrol cycle, which is certainly something that is a concern as well.
I want to come back to that in 1 minute.
Sure.
Like, I think we're going to take a break for pause for the cause, and then we'll come right back because Vivitrol is an important item, on the agenda,
Really
on
is.
the opiate reduction agenda. So this
Sure.
is James Sutton. I have a special guest today from Shatterproof, Rachael Cooper, and we'll be right back.
A lethal dose is in here. Who gets it? I won't know.
Scary that it can be put into anything. We can't even see it or notice it.
Hi, I'm James Sutton. This is Road to Recovery. My guest today is Rachael Cooper. So Rachael, we were just talking about medication-assisted therapy and Vivitrol in particular, and you were giving some good information about why it's not used as much by those in recovery. And I was wondering, had you noticed any policymakers that were trying to push it, because it is non-addictive. That's one of the things I like about it. But it's not used very much in my facility. There's not too many takers because there's no euphoric effect,
Yeah, I mean, not working on our policy team, like I probably have a more limited view of what's going on state levels, right? Because I think in states and also in counties as well, there are smaller programs that are really aimed at increasing utilization of Vivitrol, also known as naltrexone, and also which can be used for alcohol use disorder as well. So, on a national level, of course, we've seen incredible support for the passage of the MATE Act and the removal of the X waiver for buprenorphine prescribing, which is where a lot of the national attention has been. So we'll see in upcoming cycles, what happens not only with Vivitrol, but also with methadone as we look to, as we noted just earlier this week that they extended the take-home provisions that came during the pandemic for methadone and buprenorphine. Lots of work right now, I think, was really centered in that space. But I think locally there is a lot of work being done to increase access to and utilization of Vivitrol. Just probably less on the national level that we're seeing.
Right. Now let me just touch on harm reduction for 1 minute.
Sure.
You said you actually did some work early on in 2010 with Narcan distribution. Now Narcan, I would look at Narcan as harm reduction because we got a lot of pushback initially from some law enforcement in different states that said that we were, helping people use by giving them Narcan, and they wouldn't allow their officers to carry it, and things like that. How
I mean, to put it bluntly, it's been exceptionally important.
Exactly.
A few points I think here. One is that naloxone or Narcan is a tool that has been around for decades. It's just not something that was initially, in the hands of lay people, and certainly wasn't, necessarily in, in an EMS response kit or something like that, just due to the fact, until the opioid epidemic really started, it wasn't something that was necessarily like needed in the same way. And by started, I mean that wave in like the mid 2000s, when we really started to hear about this on a national level. Obviously, there have been, overdose related epidemics prior to this one that we're in right now. The idea of Narcan or naloxone being an enabler or increasing drug use is one that's certainly been around for a long time. And like you mentioned, I used to be in harm reduction, working in Milwaukee, Wisconsin at a needle exchange service, which also did overdose education and naloxone distribution. And honestly, what we saw, and especially in that context, was that the most powerful tool that we had was to give people who were using drugs the tools to reverse the overdose, because they are the ones that are there. And there's been a lot of work in states across the country to get Good Samaritan laws passed so that you can call in the event of an overdose and not, risk legal prosecution. But that's not the only thing that you can do here, right? And oftentimes it can be a matter of minutes. When somebody's not breathing,
yeah,
oxygen flow is critical. So when you're talking about a multi-pronged approach, you're looking at, making sure that you have Narcan and naloxone on site, also the ability to safely call for emergency services. Those are 1 and 2, but really putting naloxone in the hands of people who are going to see an overdose and reverse it. I mean, it's not a number really measure, but countless lives have been saved because of that.
Right. Yeah, I agree. I actually, I gave a Narcan training to inmates like 2 weeks ago, and we actually put Narcan in their property so that when they're released, they already have Narcan in their property when they're released from jail. And that's not just for opiate, dependent people. It's for anyone who wants to be trained, right? Because anybody, you can go into Starbucks and just to get coffee and find someone, in the bathroom trying to, shoot up something, fentanyl or whatever, So it's important that we all, are trained and have Narcan. I got it in my glove compartment, so, it can't hurt. It can't hurt.
Exactly. And I think that last thing you said there, that it can't hurt, like that's so important. What Narcan does, or what naloxone does, is it blocks your opioid receptors essentially. And if there's no opioids in your system, it's not going to do anything. If there's other substances there, it's not going to help or hurt. But I do think that's one of those key things, is that what we don't think about, or what we get scared of is like, what if I accidentally hurt someone? What if I'm wrong? I'm not a medical professional. What if it's not an opioid overdose? And honestly, the beauty of Narcan in a lot of ways is that if it's not an opioid overdose, you're not going to hurt anything. It can only help, and it can't hurt. So that's always a really essential take-home message that I hear as well.
Right. And I'm glad you mentioned a Good Samaritan. In Maryland, I actually was one of the people that went and testified in the Judicial Committee in Annapolis to get the Good Samaritan law in Maryland. We have it in Maryland now, and we just actually improved on it, on the original one. We just added some more, we did an amendment to improve it, right? So that's so important, because in the back in the day, no one wanted to get in trouble. Right. So they would allow people, their friends, to die from alcohol and from opiates,
Right.
Because ours includes alcohol too, any kind of poisoning.
Right, exactly. And like the term, drug poisoning in this case, meaning any sort of drug overdose. It's certainly, the more protections that you can give, and it still takes time to trickle down, right? Does it, there's all sorts of associated questions, right? Does it protect against like a probation or parole violation, for example, is a question.
Yeah, ours does.
Yeah, exactly. Yours does not, but not all states do, right? So it does depend a little bit on I think there's a lot of those questions as well, and a lot of trust that goes into making a phone call like that still, but is critical. Obviously,
Right.
one of the biggest tools we have.
Right. And that's a big A. It's a big advocacy because that's on a
Yep.
state level,
Yep.
dealing with legislation, which you guys are involved in. Now, I was in DC this past weekend and they had a walk for recovery. And they had like a lot of people who have died in DC from fatal overdoses. They had their pictures, stuck in the ground, on placards around the monument. And I've never seen anything. You guys, kudos, clap, clap. You guys have that on your website. Can you talk
Yeah.
a little bit about the memorial, the National Addiction Memorial?
I'd love to, and I'm so glad that you visited that. So the National, Addiction Memorial is it's a lasting tribute to people who have lost their lives to addiction. So it's a place where families can grieve openly, where people can create a memorial and really keep their loved one's story safe, in perpetuity, right? Lovely to do walks and to have an outside display, but certainly not something that is always that's a day, right? So the idea here is to have this, people's stories live on among other significant stories of people whose lives were cut short. So it really serves as a very powerful reminder of addiction and what it can do. So it's been a very positive response. We've heard from more than 3,000 people who have lost a loved one to a substance use disorder or an overdose. It's really become a powerful symbol for families to honor that memory.
Right. And that's another opportunity to tell your story because I saw it wasn't just about the person who had
Right.
overdosed. It was also, you asked the question, what's your story?
Right.
How that person affected your life. So that's another opportunity because we all have a story.
Right. We certainly do.
And that's great that you asked that.
And well, I think about, for example, the work that you're doing, right? You're a person in long-term recovery, and what you're doing with your world right now is really still working in that space, in that field. So our stories, we don't know where they're going to go, right? They don't stop. And also, even when somebody passes, their story doesn't stop. It can continue to change lives. And that's a really key, behind all of the work that we do at Shatterproof, from working to, revolutionize the treatment system, to increase access to and quality of treatment, to the stigma reduction work that we do with healthcare providers, that we do in communities, to really creating that community change and empowering community voices. Our stories aren't done. And we all have, infinite capacity, right, to continue to work in this space and create the world that we want to see. And that the National Addiction Memorial is very much part of that process.
Yeah, it was very moving. And we Tree of Hope, we actually during the pandemic, we had an opportunity to create something that is very, useful in our area. We Latanya Rich, she created a listserv in Maryland where if you have a person that you're trying to get into treatment, you can go to this listserv and it's like a town hall meeting, and we get providers to come to the listserv. And so instead of being in competition, the providers, all you have to do is say, like, I have a person that's like 26-year-old alcohol dependent, has Medicaid. And you can go to the listserv and the providers will say, I have a bed, so it's like,
Right.
It's like treatment on demand, and
Yeah.
this is during the pandemic when, services were at all-time low. You could, many places were shut down, their staff was infected, they had, limited capacity to serve, so we did that and it's like free. So it's cost effective and it was a way that we have like over 250 providers.
That's amazing.
That on the listserv, so we can, kind of provide services for people who may not have gotten it before because they wouldn't have known where to go,
Right. And I think that's a great example of the power of community. Especially in that moment when everybody was like, okay, I don't know what to do. Nobody had really lived through a global pandemic, right? So how do we navigate? What do we do? And recognizing the increased need, and then, I think all of us in the field were anticipating the subsequent spike in substance use and overdoses.
Yeah.
What do we do? Both from a reactive standpoint and also from a proactive standpoint, how do we navigate that space? I think that's an excellent example of community just putting aside saying, this is what we have to do to do this work. Let's get it done and let's make it happen and let's make it accessible.
Right, right. And so, we did see exactly what you said. We saw more domestic violence. We saw, because of the isolation, we saw more people, the alcohol use went up, and also, of course, fatal overdoses, because, we always suggest never use alone,
Right.
and this was the opportunity. I mean, this was a time when people were actually isolated and were alone more than ever, unfortunately.
Right.
Yeah.
And I also think about from kind of like going back to the stigma part a little bit, when you think about for anybody, I mean, we all lived through the lockdowns, right? Those first months, weeks and months where many people were very alone for long extended periods of times with their entire life disrupted and all of their social routines and all of their community being disrupted. And, I often draw a parallel a little bit to, remembering what that felt like for us in our hearts when our entire world got disrupted. And then draw the parallel to people who have a substance use disorder, who are using and who are experiencing the stigma and that associated social isolation, right? That comes from being stigmatized against, that comes from experiencing people's biases and saying, when you feel like people don't want you there, like, how do you seek help when you don't think you're going to be able to get help? How do you seek help when you don't think people are going to accept you? So it's one of those kind of key take home points for me that to remember, for all of us to remember that social isolation is not only dangerous in terms of overdose, like you said, never use alone, et cetera, that very important message, but also what does the ongoing social isolation do to our mental well-being and to our communities? And what does it take to kind of undo those impacts?
It's true. Yeah. That's the thing. These are our brothers and sisters, neighbors, they're human beings. And,
Right.
I mean, I think I've been trying to get Impact in Canada. I've been trying to get them on my show for a while because I think they're doing a great job. They have just to have that opportunity to connect with people who never seek treatment initially, right?
Right.
Because only I think the statistics say like what 10% actually come to treatment, and the 90% are still using on the street with no treatment, right? So those are the people that we need to go after, the 90, right?
Right. And you got to do it in like multitude of different ways, right? We need all of the tools in the toolbox, which I think goes to the conversation we were having about Vivitrol, goes to the conversation about naloxone and prevention and increased access to treatment. Not only does it take all of us, but it takes a full toolbox of tools to get to, the vast majority of people that you just mentioned that may need treatment and aren't able to access it for whatever set of reasons.
Right. And I think, organizations like yours and mine, I think we're touching, so many different diverse communities, and we actually focusing and working together, which is a good thing on any subject, right?
Right. Certainly is.
And it's and we're forging some great partnerships, working on the opiate crisis. And I'm glad that you're one of our partners. So I don't think we have too much time left. Is there anything that we didn't touch on that you wanted to mention?
Could talk for hours. I think from a kind of a take home, if the kind of the question is, okay, so here's all this information, what do I do? Right. Is I think, there's a few, just a couple things that I would mention quickly, aside from, of course, please visit the National Addiction Memorial, stop over at shatterproof.org and learn about the myriad of things that we're doing, because there's way too much to talk about in this conversation. But from very specifically from, we know that stigma drives overdoses. We know that it drives the overdose crisis in a lot of different ways, from everything from not enough healthcare capacity, not enough treatment providers, to like the social isolation that I was talking about before. But what we can do just on that individual level, remembering that like the idea, two things. One is the idea that like 2 minutes can change somebody's life for the better, right? So what happens in those 2 minutes when you're with somebody who's experiencing something like this, when somebody discloses, what does that 2 minutes look like, right? What can we do to kind of prepare for that 2 minutes? It's knowing local resources. It's, making sure to kind of reach into like your compassionate self and to being able to not only empathize, but to problem solve, because sometimes problem solving is a part of the things that you can do, really giving that, non-judgmental, practical space. And then remembering that language matters. And not only does it matter like when you're talking to somebody, so, avoiding, stigmatizing terms, using terms like person with a substance use disorder, avoiding terms like addict or junkie, those very difficult terms to hear, but also remembering that not only when you're in that situation, but when you're out in the world, you don't know if your neighbor has a substance use disorder, or if your kid's teacher does, or if, a person at the grocery store does. But when we use language like that, even, loosely or without really thinking about it, it can really impact somebody's well-being and really make them feel like they can't seek the help that they need when they need to. So just remembering that our language matters, our words and our tone matter, and understanding what do we have available in the community or what's out there to be able to help people navigate in those terms, those times of extreme vulnerability.
Right. All right. Thank you so much. I'm gonna have to have you back because, like you said, you could talk all day.
Anytime, man. I'm around. Would love to.
You guys do such a great job. This is James Sutton. My special guest today was Rachael Cooper, the Senior Director of National Stigma Initiative with Shatterproof. Go to their website. They have a great website. It's very informative, educational. Even if you're seeking treatment on a national level, you can go to their website and they have a locator that can help you wherever you are. So again, thank you for being here today, Rachael. This is James Sutton, and I'll see you on the road to recovery.